Okay. All right, well, good afternoon, everybody. I hope you all are staying safe and healthy. I want to thank Martin for the opportunity to give this presentation today. This is the first time I've given a presentation in front of a camera instead of an actual room of people, so it's a bit of a new experience for me, and I'm hoping that it seems this doesn't seem unduly awkward. What I'd like to do today, talk about myself. My name's John Robinson. I practice in Santa Rosa. I'm also on the oral medicine faculty at UCSF, where I have or been a part of that clinic since the early 90s. My presentation today is going to be on diagnosis and management of various oral lesions and conditions. These are all of the slides that I'm going to show you are slides that I've taken myself. They're things that I've actually seen either in my office in Santa Rosa or in my clinic at UCSF. So if I've seen them, you can see them. And so I hope that you will find this relevant in terms of the types of things that you see in your own patients. My purpose today is to do a general review of the more common pathologies that we see in the oral cavity and also their management. I do want to spend a bit of time reviewing the process of differential diagnosis because that is really critical to this type of care. And also, I want to go over various therapies, and I'll give you some little tips and pointers of things that I've learned along the course of my career that I think might help you to be more successful should you want to get involved in this kind of care and try to help some of your patients. So I've been a member of the American Academy of Oral Medicine most of my career. I'm a past president, and I don't know what, anyway, I think without further ado, I think we'll just launch into the presentation. If I can make my slide advance, which it's not advancing. Why is it not advancing? It was advancing before. Okay, Martin, why did it work before and it's not working now? There we go. Okay, so I have no disclosures. Considering my office is closed, I wish I had some disclosures, but I don't. And I also want to note that much of the prescribing that I'm going to talk about today is off-label. Oral medicine, our academy has a kind of a convoluted definition of oral medicine, but bottom line in my view is that we're managing the medical disorders that occur in the oral cavity and related areas. And it also applies to dental care that's provided to patients who have significant medical concerns that require modifications in treatment planning and treatment delivery. Today we're going to focus mainly on the medical disorders of the mouth. So there are medical disorders that affect the oral cavity. There is no specialty of medicine that deals with them, though. And now that there is a specialty of dentistry, we can say that the appropriate specialty for these problems is, in fact, the specialty of oral medicine. And diseases of the mouth may be just that, just related or just involving only the mouth and unrelated to anything else. Or they may be part of a larger medical problem, such as something like Crohn's disease, Pemphigus, metastasis from a distant cancer. It also may be secondary to some underlying medical problems, such as a patient who has candidiasis and has diabetes as a predisposing condition. Problems in the mouth can be iatrogenic. They can result from medical treatment, such as when you have dry mouth or ulcers that can result from medications. Cancer treatment is a good example of something that will cause problems in the mouth. But from time to time, patients will present to our office with various mucosal complaints, and you may see things that look like this. A red spot on the gums, this white area on the gum around this tooth, another problem on the gum, and then all of this inflammation and these white changes on the tongue here. So all of these things are cases that presented to my office. Sometimes these are asymptomatic, and we note them just in the course of a dental exam. Maybe the hygienist picks it up in the course of a cleaning, and they're asymptomatic. Sometimes they're just a minor annoyance to patients, but sometimes they're extremely symptomatic and really interfere with quality of life. And sometimes, in fact, they are actually life-threatening. They may also be what brings the patient to the office and may constitute the chief complaint. And what we would like to do, we'd love to be able to provide a cure, but in any event, if not a cure, then effective management and to prevent progression of the problem, prevent secondary problems such as trying to prevent decay problems in somebody with a dry mouth, and then make them more comfortable. So it always comes up, who is the best person to provide this type of care? Well, now we have oral medicine as a specialty, so I would say probably the oral medicine specialist, but there really are not very many oral medicine specialists around. So a lot of these things wind up at the oral surgeon's office, and oral surgeons are very qualified by and large to diagnose problems in the mouth and sometimes even initiate treatment. But in general, surgery being a specialty that tends not to see patients on an ongoing basis, they tend not to provide ongoing treatment for chronic diseases, and it winds up back in the dentist's office. A lot of these things get referred to periodontists, and sometimes they wind up in medical offices too. So I would say whoever knows how to take care of a given problem is appropriate to see them. There's a lot of barriers involved in providing this care. Sometimes we have a lot of billing and reimbursement problems sometimes. This occurs a lot of times, especially with patients who have network medical plans which exclude dentists from participating, because these are medical diagnoses oftentimes with medical codes and are therefore billable to medical insurance. Dental plans are not very well set up to provide this kind of care. As I said, dentists get excluded from provider panels. In the case of a lot of dentists are not really that interested in providing this kind of care. They don't see it very often. They're not familiar with the problems or their management. They don't have the confidence, and so they're uneasy trying to get involved in it. So patients can have a hard time finding somebody to take care of them. And then there's also the issue of what the public, and I would say include in that the medical profession, what they perceive the scope and nature of dental practice to be. Dentistry has become highly, I would say even in many cases, almost exclusively associated with teeth and dental problems. And a lot of people are not even aware that we do anything besides deal with problems associated with teeth and cosmetic issues. So this results in people having a hard time finding management and effective treatment for these, and they get ineffective and inappropriate referrals, which wastes a lot of time and money. There's delays in diagnosis and in treatment, and sometimes these diseases then go on to progress. I would say that 80% of the problems that I see both in my office on referral and on my clinic at UCSF, I think probably could be managed by the general dentist or periodontist or other specialists who referred them, if they had a basic understanding of how to develop a differential diagnosis, how to do a biopsy, and it had a good treatment reference. So having said that, I'm going to, on the left is a punch biopsy, which I'm going to show how to use. And then on the right is a reference which has been very popular over the years. It's produced by the American Academy of Oral Medicine, and what it has about 30 different common oral conditions in it, with this overview of those conditions and suggested therapies provided in prescription format. So this has been a really helpful resource over the years, and if anybody is interested in finding this, they can go to the Academy website, which is aaom.com. Look on the Publications tab, and there's a whole series of these monographs available. And this one, the treatment of common oral conditions, has been one of the most popular and most useful. So I present that for your interest. So a patient comes in and presents to our office with something like this and complaining of a lot of pain. And I think, and I know that the initial reaction a lot of people have is, what is it? And so I asked myself, what is it about diagnosis that is so difficult? And I think a lot of the problem for us is that in dentistry, so much of what we do is not really a diagnostic problem. It's very straightforward. We don't even oftentimes think about the diagnosis. On the top of the slide, obviously the tooth is broken. Most of us wouldn't even think about the diagnosis of a fractured tooth. We would be jumping ahead and thinking about how we're going to treat that. If a person comes in with complaining of pain in the lower right, and we take this x-ray, the diagnosis jumps out at us. Although if you think about it, it's also possible that they could be having pain from another source, and that the tooth might in fact actually not be the cause of the problem. But the point is that in a lot of what we do with teeth, the diagnosis is very straightforward, and it doesn't really require an awful lot of workup. So the reason that diagnosis is the art of identifying a disease from its signs and symptoms. And the reason that I think that's worth pointing out is that I think that we need to revisit what is a diagnosis and why it's so important that we have a diagnosis before we start treatment. Years ago, I was a client of, early on in my career, I was a client of a management company that was really very good at teaching leadership and dental practice management. But one of the things that they used to do that drove me nuts was they used to talk about diagnosing crowns and diagnosing these different procedures, and then you know, how much money you diagnosed on your new patients and things like that. And while those are all important things, they're not diagnoses. And I think that when we start to think about diagnosis in terms other than identifying a condition or disease, when we confuse it with treatment plans and other types of things, then it becomes even more hard to zero in on diagnosis and organize our thinking. So when we see this, instead of being caught flat-footed and saying, well, what is this? We need to stop and back up and think about it and ask ourselves, what could it be? And when it comes to mucosal diseases and pain syndromes and those types of complaints, then the answer is usually could be different things. And so differential diagnosis then is the process by which we distinguish between things that look alike and present similarly. And this is a process. It's not an event. It's not like you look at a cavity in a tooth and say that's a cavity. We recognize that. We don't have to there is no differential diagnosis for that. So, but with mucosal disease, we have to usually go through some sort of a process. So we start out with the patient has a problem. There's a lesion that we see, or they have a complaint. And from there, we want to get to a final diagnosis so that we know exactly what it is they have and how to treat it. But we have to go through certain steps to get there. we'll go through, first of all, the differential diagnosis where we identify, well, what are the possibilities? And then a provisional or a working diagnosis of, well, what is it most likely? And then to get to a final diagnosis. Once we have a final diagnosis, then oftentimes we can provide a treatment that's specific, appropriate, tried and true for that diagnosis, and it'll be predictable, usually, often. If we just get to the provisional diagnosis, we can at least make a targeted approach. At the level of a differential diagnosis, we can treat from our experience based on what we think we have, but at this point we're less sure. It's a little bit more trial and error. And if we have no idea what we have, our treatment tends to be random, and we tend to do things like just reflexively prescribe Paradex or amoxicillin or something that may or may not be appropriate or useful. So how do we go through this? Well, again, first of all, we have to come up with a differential diagnosis of what the possibilities are and then sort through it. To sort through a differential to get to what we think is most likely, we do that usually by a careful examination of the patient and the lesion in question. Consider information from the medical history, the history of the condition, the history of the present illness, if you will. Social history with things like tobacco or alcohol use, any relevant family history, and then their dental history. Once we get to a provisional diagnosis of what we think this is going to be, then we can generally, we'll do some specific test for that. Most of the time it's a biopsy, but it may be imaging, it could be blood tests. In some cases, it could be culturing to try to get to a final diagnosis so we know exactly what we have. So it kind of funnels down to this final diagnosis. So developing a differential diagnosis, we start out with the patient on an initial visit. You've all been through this before. So, but just to review it, we'll get patient information, age, gender, and so forth, and why they're there, the history of their problem. What are the symptoms? Where are the symptoms? When did it begin? What has been its course? Has it been chronic? Has it been recurrent? Does it come and go? Has it gotten worse or better? Are there any things that make it better or worse? Has anything been done to diagnose it? Has anything been done to treat it? And then what's going on in the medical history? Are they being treated for anything? Past serious illnesses? Is there anything currently diagnosed that may bear? What's the status of their current diagnoses? Are they stable? Are they controlled? And how are they being managed? And it can be significant. There's a sizable percentage of people over 55 who have more than one chronic medical problems, each one treated with one or more medications. So this can factor in. What medications do they take? Are they taking any over-the-counter medications? Because some of those bear in. Some herbs factor in, although it's sometimes hard to know what some of those do. And then the medication list also makes a good cross-check against the medical history. Sometimes they take medications, but they don't list a problem on the medical history to match it. Are they allergic to any medicines? What social habits do they have? Tobacco, alcohol, any recreational drug use? And then are there any familial diseases or problems of similar conditions or related conditions, potentially related conditions? When we get to the exam, we'll note the location. Are there any is it something that is grown? How big is it? Is the color different from normal? Are there unusual surface characteristics such as is it warty? Is it friable? Is it a blister? What is its consistency if you palpate it? Is it firm? Is it soft? Is it squishy? Does it hurt? when you manipulate it. And then also our examination and our documentation should include the rest of the mouth too, just to demonstrate that we actually have looked at it and that what we're seeing is limited to the area in question. And it's better to use clinical rather than histological terms. For example, to say that something is red rather than to say that something is inflamed, because inflammation really is a histological is more of a histological term than a clinical one. And then make sure you document everything. So it is very common in medicine to categorize different types of problems and conditions. And there's different ways of doing this. For me, what has worked out well is to break conditions out into infections, immunological disorders, neoplasms, and then something I just call acquired or developmental, which is kind of an other category of miscellaneous things that don't fit into the other major ones. And then I work my way through those categories to see what fits and what doesn't for a given clinical presentation. So among the infections, we have viral infections, bacterial infections, fungal infections, and then of our immunologic problems, we have Aphthous ulcers or canker sores. We have true antibody-mediated diseases of Pemphigoid, Pemphigus, lupus, Lichen planus, and lichenoid reactions. And then allergies, Erythema multiforme. And then tumors, we have benign tumors and malignant tumors, but we also have lesions that you can sometimes call precancerous. I think of them more as potentially cancerous because it's not 100% predictable that all of these quote-unquote precancers will actually progress to cancer. And then the other final category can include things that are truly developmental or congenital, traumatic and reactive lesions, such things as cysts, foreign bodies, drug reactions, underlying medical problems, neurological conditions like burning mouth, and then iatrogenic things like osteoradionecrosis and medication-related jaw necrosis. Now, I also want to point out that this is not by any means an exhaustive list of possible diagnoses that somebody can have, but the vast majority of the things that we see are going to be on this relatively short list. So most of the things we see are not going to be some esoteric thing that you're more likely to find in a pathology textbook. So again, with differential diagnosis, what are the possibilities? And within reason, include those things that are consistent with the signs and the symptoms and the history, and don't include those things that aren't. And remember that you can have more than one thing happening at the same time. Although we like to find a common denominator whenever we can, the fact is that sometimes there's more than one problem. This cartoon I just put in there to make the point that start out by thinking inside the box, because most of the problems are going to be on that short list. And this cartoon was just to say that try not to think outside of the box, at least until you've looked really thoroughly inside the box. There's an old saying about hearing hoofbeats and looking for zebras. So once we have a differential diagnosis, the first thing we want to do is make sure if there's something that's an emergency, we need to deal with that right away. And that would include if you think you might have temporal arteritis or Ludwig's angina or something that's potentially life-threatening, angina pectoris, refer or treat immediately so that doesn't become a big problem. Then if you're considering something really worrisome, like cancer or maybe pemphigus, you have to have some sort of a plan to diagnose, to make your diagnosis and either confirm it or rule it out. And again, multiple diagnoses are possible. We want to consider the diagnosis that's most consistent with the history and the clinical exam, and then that will be our provisional diagnosis. So back to this picture again, this was a person who came to my office some time ago complaining about the red spot on their gums. It wasn't, they were a little bit sensitive, but mostly they thought it was a cosmetic issue. So I would describe it as a generalized red condition, rather unimpressive, not very specific looking, and mildly symptomatic. And that, you know, out of the infection category, I might consider candidiasis. From autoimmune conditions, you could see Lichen planus or a lichenoid reaction present that way. Also, Pemphigoid or Pemphigus in an early stage could present that way, and it could represent an allergy as well. Once upon a time when we used to see a lot of oral problems related to HIV, that might have been consistent with a Kaposi sarcoma. And then as far as something that might be acquired, this could be an area of trauma, and we could probably rule that in or out by history. So what's the most probable? We've gone through a history, gone through an exam. So here's our exam. Let's really look at it in a little more detail now. If we look at it, we have this area that's erythematous and somewhat atrophic, where the mucosa looks a little thinned out. And then over here we have these little white patterns, which are kind of lacy. And as you start to use those terms, you think, lacy, that, Lichen planus is described as a lacy white pattern. So back from that list of potential diagnoses, then Lichen planus, I would move Lichen planus up to the top. So to get to our definitive final diagnosis, what are the things that we could do to establish the diagnosis of Lichen planus? In this case, it would be a biopsy. That's the best way to distinguish between those entities and confirm Lichen planus. Do we order a special test? Probably would order direct immune fluorescence, because pathologists like to have that to help establish Lichen planus. Now, direct immune fluorescence is a test that's used mainly for antibody-mediated diseases, and Lichen planus is not that. But Lichen planus does have fibrinogen deposition, and the immune fluorescence will detect that. So direct immune fluorescence is useful for diagnosing Lichen planus. So other tests that we can do, this was another case that presented to the clinic, had this kind of brown soft lesion in the palate, and the people who sent it up were concerned about melanoma because it was dark, so they wanted to have it biopsied. But because it was very soft, I wasn't sure if it might be vascular. We took this X-ray and noticed this cyst in the midline here. So this was basically a palatine cyst, an incisive cyst, incisive canal cyst. So this is an example of the punch biopsy being used to sample some some tissue from a generalized area. So this is an incisional type of a biopsy where we're sampling the tissue to make a diagnosis. This is a little lump on the tongue, probably a fibroma, but we can also use that technique to both diagnose this lesion and to remove it altogether. So a little anesthetic, a little, use the punch biopsy around it, and there's the specimen, and that's what's left. We don't have to put a stitch in it or anything. It just, it'll just heal up on its own. So this is one company that makes these punches. I like the 5mm size. It's just kind of a general good all-purpose size. It doesn't leave too big of a defect. It heals pretty readily, and it's big enough to remove things like fibromas and warts usually. So I have a little video here showing the punch biopsy done, And this is a super useful technique. Let's see if I can make it go. There we go. So here we're going to administer the anesthetic. It's just an infiltration just beneath the lesion. I take my time because it doesn't hurt as much. It's a 30 gauge needle with a bit of lidocaine. I just move it in and out a bit to anesthetize the field. And it also tends to lift the lesion up a little bit and make it a little easier to get the punch around it. And if you're slow with the infiltration, generally by the time you've given about half a carpule, you're done, you're ready to go. It's numb enough. So there the punch goes. And from this angle, it's a little hard to see the depth, but it looks like it's going all the way to the plastic, but it really isn't. It's only going maybe 3 millimeters deep in this particular one. You don't need to go that deep usually to get something like a fibroma off. A little bit of bleeding. Then I can use my finger on the cheek and push it so that the specimen pops up, and snip it off with some scissors. That just goes over onto a little piece of stiff paper and then goes in the bottle. You can see the bleeding is really very minimal. Now I put a gauze pad in there with a little Vaseline coating it, and that will keep the gauze from sticking to it when we take it out. And that's basically all there is to a punch biopsy for that kind of an application. So it's a very straightforward, easy technique, and it's really very useful. It doesn't take very long to do. And it gives you a really nice specimen. So some of the limitations and pitfalls in diagnosis. One, it's not an exact science oftentimes, and you can move back and forth through the process. Sometimes you think you have a final diagnosis, but things don't quite turn out the way you thought they were going to, so you have to back up and move through this process. You may have to go back and re-diagnose your case if your final diagnosis turns out not to be correct. Maybe your biopsy doesn't agree with your impression, or maybe it doesn't respond to therapy the way you thought it would, or something is changing, or something is new is happening. So this is it's not a one and you're done sort of a thing. And I'll show you another example of that later on when we get to cancers. So we have to ask ourselves, too, where are we in this process? Do we have a final diagnosis? Do we just think we know what's going on? Or do we really have something that we can have confidence in? And what is the diagnosis really based on? Do we have something definitive, some really classical biopsy result or a blood study that's diagnostic? Is it just a previous biopsy that somebody did? Well, was theirs good? Did they get the right spot? Are the history and signs and symptoms consistent? Is that what we're basing? We're just basing it on the history and the presentation, or how it's behaving. Maybe we saw something like that similar in the past, and we think that's the same thing. Maybe we treated it and we got the result we were looking for, so we make our diagnosis on the basis of that. But maybe it was the treatment that helped, and maybe it got better for some other reason. Patient's belief, the patient may tell you what it is based on their past experience or on some other criteria. Maybe their friend told them that they had something like that. Sometimes the patients are spot on, but sometimes they're not, and they can mislead you very much. So you have to be careful with that. Some people will make a diagnosis just based on the demographics. I had the experience of a family member being who had an abnormal treadmill being given a diagnosis of mild coronary artery disease because that was consistent with her medical history and her lifestyle and her body habitus and her family history or lack thereof. And it turned out that the disease was in fact far worse than what the initial diagnosis was, and it was only by luck that we happened to find it. So demographics is, some people base a diagnosis on demographics, and that's not a very strong diagnosis. Risk factors. Tobacco, for example, may make you more inclined to diagnose a cancer. Or lack of evidence for something else. These are not very strong criteria to establish a diagnosis. And it's worth asking ourselves sometimes, okay, well, here's my diagnosis, but how reliable really is it? What's it based on? There's a couple of points to be made from this x-ray, I think. One is, of course, when you look at this x-ray and see that every tooth has been treated with root canal and then an apicoectomy, you have to ask yourself at some point about the diagnostic acumen of the dentist who provided this treatment. And at some point, you think that person should have said, I've kind of reached the limits of my ability to detect the problem here. I don't think your problem is dental. And so this is where we need to be aware that there's a whole lot of things that are not dental that can act dental. On the other hand, that patient must have really felt that this was a dental problem in order to undergo and pay for so much dental treatment. So it's very possible that the patient himself and was a very strong initiating factor in having all of this dentistry done. And it may be an example of why patients' beliefs can lead you astray rather than point you in the right direction. Sometimes we never get to a final diagnosis. Sometimes the best we can do is say what something is not, and then we just have to follow basic principles in providing treatment. And so at this point, I think we'll just move straight into different types of lesions and their treatments then. In general, the options that we have for treating oral lesions and conditions is topical therapy. That's a big one. Systemic therapy. Intralesional therapy is sometimes used. We're not going to get into that too much. And then if you get past your comfort zone or can't find something that works, you may need to think about referring your patient. If you're going to prescribe, you need to know something about the drug that you're prescribing and you have some training or experience, and you may be able to train yourself just simply by doing your homework and reading a good drug reference on how to use the drug that it is that you want to prescribe. To look at the indications and the contraindications, the drug interactions, and then so on and so forth. You should only prescribe if you know what you're prescribing for. You have to have some kind of a diagnosis. And the way you prescribe it should be based on established guidelines and standard protocols, except that sometimes we modify those the dosing according to the severity of the condition, maybe the medical status or age of the patient, and also how well it responds to the treatment. So we have to check and see how does it respond to treatment. If we treat it, we have to do follow-up and see how well the treatment worked. If there is no response, it could be because we don't have the right diagnosis, the medication is just not working, or the patient's not doing what we told them to do. And if we're not getting a response, we may need to refer on to somebody who can provide something something different that we might not do. We need to consider side effects of the medications the patient's already taking. They may be mucosal reactions, dry mouth, and also some of the therapeutic effects. If they're taking anticoagulants, that may affect how we do our biopsy. We might want to have suture present or some way of some type of hemostatic agent. And then we want to consider drug interactions with what they're taking. Remember, I said that there's a lot of patients, a lot of adult patients out there taking a lot of medications these days. They have a lot of chronic illnesses. There's a lot of hypertension, diabetes, all kinds of things out there that they're taking multiple medications for. Sometimes these drugs have added effects. Sometimes they interfere with each other. And whether the drug that we want to prescribe is available, if it's affordable, make sure they're not allergic to it, and then other contraindications, some sort of medical problem that would contraindicate its use. And have a good drug reference, which is pretty easy because there's a lot of good stuff online right now. So I would like to go through these various categories of disorders in order as we start talking about diagnosis and treatment. I'll give you some examples of these. So to start with infections, in discussing bacterial infections, it's kind of a non-issue from the standpoint of mucosal disease. There's a couple of viral infections that are important. The fungal infection is very important. But bacterial infections almost always are dental. They're going to be perio or they're going to be endo. It's extremely unusual to have bacterial mucositis. You just don't get like strep mouth. And I see people go into medical offices all the time and they get cultures done. They swab their mouth and it always grows out oral flora. It is just almost never helpful. So bacterial infections are not big players in this area. However, you can see some unusual periodontal infections. This was actually sent to me by a periodontist because he thought it looked very strange, and it did. But it shed this piece of bone, and then it healed up. And it healed up with a little bit of a defect. And this reminded me very much of the periodontal infections that we used to see with AIDS, which were much more disseminated and aggressive, but it was like a very aggressive focal periodontal infection that was destructive and actually shed a bone sequestrum. But it was just a bacterial periodontal infection, an unusual one, albeit. Then the classic signs of bacterial infections are going to be, purulent exudate, maybe a fistula, and they're usually going to have pain associated with them, possibly swelling, and in really severe infections, you may get fever and lymphadenopathy. You've got, for dental infections, you'll have radiographic findings, usually periodontal findings. Don't usually culture unless it's a big abscess and you aspirate it. I don't typically culture these infections. Culturing periodontal probing may be important in periodontal management, of course. The only couple times that I did have a bacterial mucositis, it was diagnosed on biopsy. So bacterial infections, again, this is just dental things. I don't want to spend a lot of time on it, but you got, antibiotic rinses like chlorhexidine. You can make tetracycline rinses. People used to use, and still do, use betadine as a rinse. You can cut it in half as long as they're not allergic to iodine. The systemic antibiotics, and then if there's any foreign material, you want to debride things, clean them up, and so they'll heal and drain off any pus. So of the viral diseases that we see in the mouth, the ones that are most important are the papillomaviruses and herpes family. Papillomaviruses produce in the mouth warts, and herpes viruses, you have herpes simplex, zoster, and EBV. Cytomegalovirus you see very rarely, and it's almost always in cases of immune suppression. So of HPV, there's about 40 different types. And the oral warts are generally produced by types 8 or 11. HPV 16 is highly associated with oropharyngeal cancer, and so is 18, but mostly 16. There are others that will rarely produce cancers too. Like I say, there's 40 types so far identified, but these are the big players. They now recommend vaccination for adolescents, and vaccination is approved for ages 26 to 45. The current HPV vaccination covers 9 different strains of HPV, 2 of which are associated with warts and the others with cancers. So for our purposes and treating warts, the treatment mainly is just to remove it surgically, just excise it. If you have multiple lesions or the big flat ones, that can be more difficult. They can be very persistent and tend to recur, especially in the setting of immune suppression. If you have a little just solitary warts, a differential diagnosis could include probably a fibroma mainly, or a scar. For the flat ones, your differential diagnosis could include frictional hyperkeratosis or other types of leukoplakia. So this was a case from years ago in a patient at AIDS, but he had kind of this classic situation of all these warts all over his mouth. And this is a real management problem. You can't, it's not practical to cut all those off. You can debulk some of them, but they kind of grow back. But you're always playing whack-a-mole with these. Now, herpes simplex is a ubiquitous virus. It's pretty much everywhere. I think pretty much everybody's familiar with the classic cold sore or fever blister that forms on the, around the lips. They form a blister and then they rupture and form an ulcer, and the crater then heals over. They can be pretty sore. While they're in the vesicular stage and while they're weeping, they are contagious. There's a lot of viral particles there. These can be picked up and spread to other sites of the body. They can, so people who have these should be advised not to touch them, and out of risk of spreading them to their eyes or other areas. Typically, these recurring herpetic lesions will affect the keratinized surfaces of the mouth and the skin, as opposed to the non-keratinized. So that's one of the ways of distinguishing them from aphthous ulcers is by the site of involvement. However, if you have lack of immune competency because of some underlying immune disorder or because this is a primary infection and the person has no immunity to herpes, you will see a more generalized expression of the infection, and it will affect, it can be anywhere. It can be on the palate, it can be on the cheeks, it can be all over when you have, so this is not a hard and fast rule. But in general, if you have these ulcers on the keratinized mucosa, that's going to point you more to herpes. The recurrent form of herpes, they tend to be more solitary, again, unless you have some immune problems, in which case they may tend to escape the immunity more and be a little bit more generalized. So you should consider herpes as a diagnosis when you have ulcers on the palate or on the gums, on the dorsal tongue, or any crusted lesions on the lip or perioral skin, on the vermilion border or vermilion, and your differential diagnosis in there would include Erythema multiforme or some other vesicular erosive disease, particularly EM or Pemphigus. And there's also a question about a risk of Bell's palsy developing after herpes infection. Herpes has been implicated herpes has been implicated as being a trigger of Bell's palsy. So you can advise patients to be alert for any drooping of the lips, or the commissures, I should say, after a herpes infection, and to if they experience that, then to go right away to an emergency department. So this was a child with a primary, what's most likely a primary infection because you have this more generalized involvement here. You've got these crusted lesions on the lip, also down on the skin inferior to the vermilion there. You can see one on the upper lip. You see the dorsal tongue, but also kind of extending out to the tip. Palate. And so they're just all over the place. And people with this many lesions are going to tend to be sick. They're going to be, they're going to have malaise. They're probably going to have lymphadenopathy. They may have a fever. This was a case, this was a herpetic lesion on the cheek, but this was somebody who was being treated for cancer and was having immune issues as a result of chemotherapy. Also on the dorsal tongue and the palate. And you can see some of the intense edema that can be involved with these cold sores. This is just going to be teeming with virus. Another one, and then there's one on the skin in the perioral area, and a couple more on the palate. So in general, we don't usually have to treat these lesions very much. We tend to be more treat them more prophylactically than therapeutically, because by the time that we see them, they're usually on the mend. If you do want to treat them, valcyclovir, 2 grams in 2 doses, 2 grams followed by 2 grams 12 hours later is the regimen if you're going to treat it. But in general, usually by the time we see them, there's not much point in treating it. If they get recurrences very frequently, you can treat with valcyclovir daily as a suppressor or as a preventive. Acyclovir is also used to prevent recurrences. And then because sun is a frequent trigger of recurrent herpes infections, the use of a sunblock is always advisable. And then we try to tell people to make them aware that this is a transmissible. Not only is it transmissible to other people by physical contact, but they can spread it around their own body by touching their place. So they should wash their hands a lot, get a new toothbrush when it's healed up, and so on. Avoid, kissing. Zoster is another one you will occasionally see in the mouth, and that's what I showed this picture earlier. That's what this was. This was a lot of pain associated with this, but she had a hard time opening. But you can see the unilateral presentation of these ulcers on the and all that exudate on the tongue. She had lesions on a rash on her face on the right side also. Now this is something that we used to see a lot in when we used to see a lot of AIDS-related lesions. This is hairy leukoplakia. And hairy leukoplakia is basically the recurrent form of Epstein-Barr virus, which tends to emerge in situations of immune suppression. It was not previously recognized prior to the AIDS epidemic, probably because they didn't persist. But because we would see these persistent white lesions, eventually they were biopsied and a new entity was identified, and ultimately it was linked to Epstein-Barr virus. EBV is the virus also, you may remember, causes infectious mononucleosis. So it's another herpes family virus that's very common, but it tends not to be a big player. We used to see it a lot. We don't see it very often anymore, but occasionally you do see it unexpectedly. This was something that it's not very impressive in this picture, but when I saw this 77-year-old lady for a hygiene recall, I saw this lesion on the side of her tongue, and I was concerned that she had dysplasia. I stained it with toluidine blue, and it definitely picked up stain, which is sort of a warning sign for dysplasia. So we biopsied it, and it came back as hairy leukoplakia. And I thought, well, why in the world would a 77-year-old married lady have hairy leukoplakia? And it turned out that she was using an asthma inhaler for asthma. It's a steroid inhaler for asthma. And so what she was getting some localized immune suppression and allowed this to emerge. And I saw one there. So we do occasionally see this come out in cases of immune of suppression. So mainly with for treating some of these viral conditions, we have excision for warts. We have systemics for herpes. Intralesional, we used to use those on warts sometimes, but that's not really, it's really, there's not really anything there anymore for that. Topicals, there's not really good topicals either for HPV or for herpes. There are some products available, but they're not all that effective. One of the big fungal infection, of course, is candidiasis, and this is something that we see a lot. We diagnose it mainly by its clinical appearance and history. You can do fungals, you can do potassium hydroxide staining for it, but by and large, just on the clinical appearance and history. It's also possible to culture it and treat it and see if it responds to treatment. Often it will present with a burning sensation. There may be complaints of metallic tastes or other taste changes. They may complain of their mouth feeling dry. That's pretty common. You may see balding, depapillation of the tongue. There may be red changes in the mouth, particularly on the buccal mucosa and palate. You'll see the so-called curd-like plaques that everybody sees with pseudomembranous candidiasis. Angular cheilitis, a breakdown of the commissures that they used to say was because of collapsed vertical dimension. And then a lesion called median rhomboid glossitis. Predisposing factors, immune suppression, underlying disease and debilitation, having been treated with antibiotics or steroids, and those can be systemic or topicals or even inhalers. Xerostomia will predispose, and also wearing removable dentures. So there's different presentations, and I'm going to show them all to you. There's the classic pseudomembranous kind we've all learned as thrush, but a lot of times the other presentations are not really recognized very well. This is a classic pseudomembranous thrush. We all would recognize this. These are the scrapable white lesions that a lot of times will leave bleeding raw surface underneath. But this one is more subtle. This one you see a depapillation of the tongue, and you might think, well, that looks like geographic tongue, which it does and would be reasonable to include in a differential. But what you don't see here is you don't see the typical white border associated with the geographic tongue. Here you have these kind of diffuse, blotchy red changes on the buccal mucosa. You also happen to have some white colonies there also. But this is a good example of the erythematous form of candidiasis. A lot of times these people will complain of burning. Here we go. Here's our angular cheilitis, where the commissures are breaking down. This is fungal, and this is a worse one. Median rhomboid glossitis, I was taught in dental school that this was a developmental disorder, but it has since shown to be result from chronic long-term candidiasis, even though the rest of the tongue looks perfectly fine. Here's another example of the atrophic candidiasis, where you see again the depapillation on the anterior tongue. Again, notice there's no white border like you might associate with geographic tongue. You could also consider a hypersensitivity condition in that differential also. The treatment for candidiasis, my preferred treatment for yeast infection is fluconazole, 100 milligrams for 2 weeks. It can be given, traditionally it was given with a 200 milligram loading dose, but you don't necessarily need to do that. just a 14-day course of fluconazole. Now, very, very well-established yeast infections can sometimes take several weeks, 6 weeks or so, to resolve. But in those cases, what will happen is I'll usually start somebody out for a couple of weeks, and if they're improving but not completely better, I will just keep them on that until it either plateaus or is asymptomatic. Ketoconazole we don't really use too much anymore. It's kind of hard on the liver, and fluconazole has been so good that that's really the treatment of choice for the systemic of choice anyway for candidiasis. There are, for people who cannot take the fluconazole for one reason or another, we still have the clotrimazole troches, but they have to be dissolved, and that it's hard to do if they have a dry mouth. Other options are nystatin. You can have the problem with nystatin suspension mainly is that it's 50% sugar by weight, and that can be really tough on teeth if you have a dry mouth. Also, it's probably the least effective of the antifungals. I do have a couple patients who are on long-term nystatin treatment because of recurrent fungal infections, and I've been able to get them compounded sugar-free nystatin at a compounding pharmacy, which works actually really quite well. They can also make sugar-free troches, but then you get into the expense of compounding. If they have dentures, you can put antifungal ointments or powders in the dentures. The dentures make great applicators if they have denture stomatitis. Dentures can be harbors of candida, so disinfecting them with some bleach in the soaking water can be helpful. Some people are prone to getting recurring fungal infections and need to be on some type of maintenance. That can be sometimes clotrimazole, but I do have patients on maintenance fluconazole. I don't really like using antibiotics on maintenance, but sometimes you just don't have any choice. Fluconazole has been a really, really good drug. It's unlike the other antifungals. It's mostly excreted in the urine. It's not as hard on the liver as some of the others, although a lot of people don't know that. It is metabolized at cytochrome P450, which means it interacts with certain drugs, the most important which are warfarin, Coumadin. So people who have had like AFib or sometimes, well, they're not using it so much for stents now, but usually AFib, they'll be on Coumadin, or for whatever reason they're on Coumadin. That's a contraindication to use fluconazole. If they're taking a statin, that's also, it may cause the statin to build up in their system and cause side effects. So I will usually discontinue the statin for the duration of the time that they need to be on the fluconazole, and then they can start it up again. The typical dose, as I said before, is 100 milligrams for a week to 2 weeks. I usually use 2 weeks. And with the caveat that if they're symptomatic and I give them 2 weeks course, and if after a week they're not feeling improvement, I usually will have them stop, because at that point I would decide it's probably not a fungal infection. So if you have a patient who comes in with some of those symptoms, these are things that may promote or may set up for a yeast infection patient. If they have fasting blood glucose is regularly running 135 or 140 or more, and a lot of people with diabetes will know this because they'll check their blood sugar in the morning. I'll just ask them, what was it this morning, and what does it typically run? And if it's up in the 135 or above, a lot of times you'll see candidiasis at some level. Asthmatic patients using steroid inhalers, now they typically tell people to rinse their mouth out after they use this inhaler, but that may or may not be effective. It isn't always. In HIV, if the CD4 count is low, that's a risk. People who've had antibiotics or on immunosuppressive therapy, they're at risk for fungal infections. If they have a vesicular erosive disease, particularly Lichen planus, yeast is pretty often seen, and I'll talk more about that when we get to Lichen planus. Xerostomia, as I said, that's a risk factor, and if they come in complaining of burning, I would for sure want to rule out fungal infection. Okay, so that's really pretty much all I wanted to say on the infectious disorders or infection disorders. So we see a lot of immunological problems, or a lot of what we see in the mouth is related to an immunological problem, starting with Aphthous ulcers and, as I said, the antibody-mediated diseases also. So Aphthous ulcers are ulcers resulting from focal autoimmune processes. The exact reason for them is not totally understood. It's probably multifactorial. They can be triggered by a number of things. They oftentimes tend to be hereditary, so there's some sort of underlying genetic risk factor for them. They identify 3 forms. You have the minor form, which typically is a small ulcer. It's a few millimeters across, which tends to have sort of a yellow or gray surface and an intense red halo. Generally painful, but sometimes not always. Then there's a major form. They tend to be over a centimeter in size, sometimes much more, and very persistent. They may last weeks to months, as opposed to the minor ones, which typically resolve in 7 to 14 days. But the major ones may be quite persistent, very painful. And then the herpetiform, which is basically clusters of small ones. They may be associated with a larger medical problem. I hear people diagnosed with Behçet's fairly frequently, but the truth is that real Behçet's is not seen in the United States very often. It's more of a problem of Western Asia, particularly Turkey. It can be associated with Crohn's, and it may have to do with malabsorption problem related to Crohn's or celiac disease. And then there's a pediatric recurring form that's identified also. That stands for periodic fever, adenopathy, pharyngitis, and Aphthous ulcers. And it's something that occurs, like every month or so. There does tend to be, as I said, a genetic tendency. They may occur every once in a while. Almost everybody gets a canker sore now and then, or they may occur on a regular basis, and some people are never without them. They may have multiple ones all the time, and they can be extremely painful. And those patients that tend to get crops of them oftentimes are really miserable with them. So these are classic Aphthous ulcers. You see the little round ulcer with the red border, with kind of a gray color. This person has, there are 3 in that field there. Here's one on the lower labial mucosa, a little bit more of a deeper cratering. And then there's, in the same patient, there's this one at the commissure. That's more of a major one. Another minor one on the buccal mucosa. Now again, I mentioned before, these typically will occur on the non-keratinized mucosa as opposed to the keratinized surface. It's not impossible for them to occur, say, on the hard palate, but it's very rare. So this is a distinguishing feature from herpes, typically, is that these will be on the non-keratinized tissue pretty much exclusively. And this is an example of a major Aphthous ulcer, a couple of centimeters across, been present for several weeks, and was causing a lot of difficulty with eating and with swallowing. Most of the Aphthous ulcers we try to treat with topicals. With something this big, usually has to be treated with systemic medication, because the topical is just it's not going to get a rapid enough response from a topical on a lesion that large and persistent. Here's another major one, very ragged, and a major one to the left. That one's obviously been present. There's a lot of necrosis there. So usually topical treatments are good enough for Aphthous, and that's really fortunate, because with these people that tend to get these ulcers on an ongoing basis. It's hard to, you don't want to keep them on systemic maintenance therapy if you don't absolutely have to. And what we typically will do is take one of the topical steroids. I mentioned off-label prescribing. This is an example of a topical steroid like fluocinolone or clobetasol, and have it mixed in oral adhesive paste. And what we used to do was order like fluocinolone ointment mixed 50-50 with Orabase or Orabase B. But Orabase is no longer available. It's been discontinued. So there are substitute generic Orabase type products, oral adhesive paste, some of the pharmacies have. But in general, what I do now is I send these prescriptions to compounding pharmacies where they now have bulk clobetasol powder, and they can mix it directly into an oral adhesive paste that they either have on hand or they can mix up. So you do need to use a compounding pharmacy, and they're getting to be harder and harder to find. But they also, by mixing the bulk powder in the paste, you can get it back up to 0.05%, which is the strength of the ointment in the tube. And then it's not cut down in half as it would be if you squeeze the ointment and mix it in the paste. So that actually has been an effective treatment. And that topical regimen is good for so many of the oral inflammatory disorders. It's a real mainstay of therapy for these disorders. For when sickly, it's kind of hard to get that drug sometimes, but that's an option too. When I get the really large ones, I just tend to kind of default to prednisone unless there's some reason that I can't. Lichen planus is a really interesting disease. It's a mucocutaneous disease. It's an autoimmune condition mediated by cellular immunity. A lot is not understood about it. It has, in its behavior, it has some features of allergy in that it can be triggered exogenously by certain medications. Cinnamon is a common trigger for lichen planus or lichenoid reactions. Has a whole different variety of ways that it can present. It tends to be chronic, and it's rare to get somebody into a long-term remission unless you can identify something that is triggering it and remove it. There's a question about a relationship to oral cancer, and it is true that there is a somewhat higher, about 0.5% higher incidence of oral cancer in people who have lichen planus than in the general population. But lichen planus is generally not considered to be in and of itself pre-malignant. I do think one of the big problems with lichen planus is that it can cause the diagnosis of malignancy or dysplasia to be delayed because people see the dysplastic lesion and are not suspicious of it because of a diagnosis of lichen planus. So if we see new things in a case with lichen planus, we have to be suspicious of them, particularly if they're on areas that tend to be at risk for cancer anyway, such as the lateral tongue and the soft palate and the floor of the mouth. This is a kind of a classic presentation of lichen planus. It's kind of classic because it's on the buccal mucosa, which is a really common place. It's got these classic white striated presentation, the so-called Wickham striae. And in between the white areas, you see that the mucosa is a little thinned out looking. It has some atrophy and sometimes some erythema. So it's red and white. It's a mixed red and white lesion, but it's not erythroplasia per se. Here's an erosion. You see this really unusual white pattern anterior to the eroded area on the buccal mucosa there. This is an interesting one because if you look at the striated pattern, which tends to irradiate from the center, so that irradiate outward from the center of the lesion, some people feel that suggests a lichenoid reaction rather than classic lichen planus. Histologically, there's no real difference. You can biopsy it, but there's no way to distinguish lichenoid reaction from lichen planus. But it turned out that this person was actually reacting to a non-steroidal anti-inflammatory drug, and when that was discontinued, this resolved. Oh, that went backwards. Okay, here's another one. This is thick white striations. Again, that posterior buccal mucosa is a pretty classic location. Another case. This one, here's on the palate. This is a common way to see it too, with this all these white changes on the palate, and sometimes the area right around the teeth is atrophic and may even be eroded. So you have these milky, here on this anterior tongue here, you have these kind of milky changes. Now this is interesting, it's worth pointing out. This was in that same patient who also had lesions on the cheek and lesions on, and the milky lesions on the tongue. What I want to draw your attention to on this lesion is what you have here is you have a more fairly uniform, at least in areas, irregular but well demarcated leukoplakia. If I had known at the time that I saw this patient, which was back in the early 90s, if I'd known then what I know now, I would have been more suspicious of this, that this might be a second diagnosis of a proliferative verrucous leukoplakia, there are some pathologists that feel this presentation is very worrisome with a high predilection to become malignant. So this may be, in retrospect, a situation where you have a patient with lichen planus, and this may have been erroneously assumed to be lichen planus and may in fact represent a potentially one of those cases of lichen planus that actually developed a cancer independently. So when you see a lesion like this, this is one to be taken seriously and watched very carefully. This is lichen planus on the dorsal tongue. You see this kind of mottled, leathery sort of look. Sometimes the dorsal tongue will have a cobblestone appearance. That's pretty common too. So if we can identify some offender that may be causing the lichen planus, I mean, that would be great. Some dental product, cinnamon, some medication, maybe we can remove the cause and get resolution. That doesn't happen very often. We can certainly always change their toothpaste, or even more, we can take them off of toothpaste altogether and just have them brush with baking soda for some time period to see if it gets better. Now consider with lichen planus that candidiasis is often it's often present at the same time, and oftentimes the candidiasis will produce the symptoms that are associated with lichen planus. A lot of times lichen planus is not that symptomatic. Sometimes it is, but oftentimes it's not. And so when it is symptomatic, it may be caused by lichen planus, which is occurring at the same time. So I will typically start out with a course of antifungal when I have a case of lichen planus to see what kind of benefit I can get from the antifungal. Direct immunofluorescence and a biopsy for direct immunofluorescence may aid the diagnosis. To do immunofluorescence, you need to take a second specimen along with the first and submit it in a separate transport medium. If you're interested in doing that, talk to the pathology lab that you want to use and have them send you some transport medium for it and tell you how to handle it. Or you could call me and I'll tell you what to do with it. But in any event, in a case with lichen planus, we want to make sure that we see them. If I have my cases of lichen planus, I always have on recall so that I can look and make sure that everything I see that's abnormal is consistent with lichen planus, and that I can be available to address anything that's new or becomes suspicious. So again, with treatment, it may be mild and not require treatment. Sometimes they'll complain about the way it looks, and that will be what will motivate them to treat it. Antifungal treatment is often necessary for the symptoms. If you have lesions that are just, if it's limited to the gums, there's a tray that you can make to deliver the topical steroid, and I have a picture of that I'll show you. Usually we use the same fluocinolone or clobetasol mixed in oral adhesive paste to apply topically to the lichen planus. As needed, usually 4 times a day, or with backing off as it responds. Severe cases of lichen planus may require systemic treatment, and there again we're kind of back to steroids usually. So this is it. But I said, if I have a severe case of lichen planus, a lot of times I will use some prednisone to get it under control, and then try to manage it with topical steroids, so they don't have to do ongoing steroid maintenance. But I thought I'd show this one. This was a case that I treated in a different way, and it's kind of topical, as given what's happening today with COVID. This was a lady who, this picture represents lichen planus after a course of prednisone, so it had already it was probably 50 to 60% better than when she presented. She had quite a bit of discomfort. Her discomfort was not alleviated with antifungals. She really had a painful erosive lichen planus condition. So I treated her with prednisone until she was comfortable, which took, I think, about a week or so, 10 days, and she felt better. And then I tried to manage it with aggressive topical treatment, but that did not help her. She broke through, and so I was back to having to consider to use steroids. She was an older lady, and I didn't really like the idea of long-term steroid maintenance for her, so I started thinking of alternatives. And something that we never used at UCSF, but I have, again, my friend at Penn, is something that he had used, was hydroxychloroquine, which is, as you probably have heard recently, is commonly used in this country for rheumatoid arthritis and lupus. It's sort of a medium strength immune modulator. And he had some luck with refractory lichen planus with this, so I thought, well, maybe this would be a good thing to try. So we got an ophthalmology clearance for her and started her on just a couple 100 milligrams a day of hydroxychloroquine. And you can see it's also on her gums. It doesn't show up all that well in this picture, but she had a fair amount of gingival involvement as well as a buccal mucosa. And it was several months, but after several months, she was completely clear and has no symptoms and no pain at all. After she was on it for about a month, she wasn't sure. She thought she'd try to stop it, and it came roaring back, so she went back on it and doesn't want to come off of it. So, but she's done really quite well on this. I thought that would be of interest to see. This is just another application for hydroxychloroquine, but in a setting of treating an oral autoimmune condition. Erythema multiforme is sort of an acute allergy. It's classically associated with a drug, especially drugs that have sulfur groups. It can be really quite symptomatic. It tends to appear very quickly and be very symptomatic, and then resolve. It tends to have more of a recurrent course than a chronic course, although in some cases it can be chronic, especially if there's some underlying cause for it. It's very difficult to know oftentimes what is causing erythema multiforme. As I said, classically it's a drug, and I have seen that happen with certain drugs, but a lot of times we just do not know. It has been also associated with viral infections, particularly hepatitis and herpes, but those things are really hard to prove. This is an example of a pretty severe erythema multiforme. You see basically all of the oral mucosa has been pretty much denuded. The lips are all crusted over, and this guy is just howling with pain. He is really, really miserable. You can imagine how hard it is to eat with all that raw surface. Ventral tongue, buccal mucosa, the whole mouth was involved in this. And the treatment for that requires systemic steroids right away. Fortunately, it tends to respond fairly quickly. So we try to find a trigger. A lot of times, sometimes it doesn't recur. It will occur once or every now and then, but it doesn't recur regularly enough to require much intervention. If it is recurring, we'll try to find a trigger. Try to have people keep track of what they're eating, what they're exposing themselves to, medications, foods, dental products, anything that goes in their mouth, to keep track of it. We can consider herpes simplex blood testing to see if they have increase in HSV antibodies that would suggest an elevated herpes simplex titer. The rationale for that is that if they have elevated herpes simplex titers, you could treat them with antivirals, and by suppressing the titers, the theory that might hold the titers down low enough that they wouldn't develop this allergic reaction. I have personally never had any success with that. Fortunately, I don't see a lot of EM, but in Europe, they talk about this a fair amount. Pemphigoid is one that I do see quite a bit. This is a true antibody-mediated disease where the body is making antibodies to the proteins that hold the epithelium in contact with the basement membrane. So what happens is that that contact weakens and the epithelium detaches from the basement membrane. You'll get these ulcers. Sometimes you'll get blisters that then they will break and form ulcers and erosions. We diagnose it by biopsy and direct immunofluorescence, and the biopsies are hard because the tissue is really, really fragile and it tends to bleed a lot. One of the complications of pemphigoid is that it can affect the eyes. You can get involvement of the conjunctiva, and that can scar onto the cornea and cause restriction in eye movement and vision problems. And so we always get an ophthalmology consultation if we have a diagnosis of pemphigoid. Oftentimes topical treatment's enough. Sometimes we'll start out with some systemics to kind of get it under control. And interestingly, almost without exception, the pemphigoid that I see is on the gingiva, which makes it convenient to treat because I can make the applicator trays and treat it with topicals in the applicator. So this is an example of the blister that can form when the epithelium lifts off of the basement membrane. Sometimes it'll be a blood blister, sometimes it'll be clear fluid, but then it'll break and you'll form these shallow ulcers. Now sometimes if you push your finger across the surface, the tissue will just sort of slide. It's like the epithelium will just slide off like a big film. In fact, I had a case fairly recently where I was trying to pick a biopsy site, and I was using the air syringe up on the teeth to kind of dry the tissue off, and it was actually, the air syringe was actually peeling back the epithelium with the airstream. Was peeling back the epithelium. There you see these kind of map-like ulcers extending onto the palate, but usually almost all of the pemphigoid I see is right around the gums. There's one that was blood-filled and it broke. So this is an example of the symblepharon that can form in the eye. You can see how the eyelid is pulling there onto the cornea. Now he can't avert his gaze medially very much because it tugs at that scar tissue there. So we want to get him to the ophthalmologist. Once it gets to that point, there's not much that can be done about it. So we want to get them to the ophthalmologist. And it really needs to be an ophthalmologist who's familiar with autoimmune diseases in the eye. So we want to make sure that they get a head start on it if they have any problems. Pemphigus is another antibody-mediated autoimmune disease, and this is one, it's pretty uncommon, but you can and will see it. I do have cases of this that I treat. And this disease is more serious. Although it starts in the mouth, as it tends to develop, it has the potential to involve more and more body surfaces, and in some cases may affect large areas of the skin. And if it gets to that point, it can be really a life-threatening disease. It usually is fairly slow to progress. It targets the desmoglians, which are the proteins that hold the epithelial cells to each other, so that unlike Pemphigoid, where the epithelium lifts off from the surface, these cells just sort of detach from each other and the epithelium disintegrates and you have a raw surface there. Whereas Pemphigus, mucous membrane pemphigus tends to affect the mucous membranes and not the skin. Pemphigus can be anywhere. By the way, there is also a type of Pemphigoid that tends to affect the skin and not the mouth, called bullous Pemphigoid. I didn't talk about that because we don't see it in the mouth very often, occasionally, but not that often. One of the difficult, occasionally if you have a case of Pemphigus that's not super aggressive, it will just be in the mouth and you can manage it topically. But because of the tendency of Pemphigus to spread outside the body, systemic treatment is often needed, and ongoing systemic maintenance treatment is often needed to keep it from developing. So this is diagnosed by biopsy. There's also a blood test for Pemphigus that can be done. Direct immunofluorescence is often helpful, although I did have a case of Pemphigus that was negative to direct immunofluorescence, which I'd never seen before. And response to treatment is oftentimes pretty slow. So when you start treating this disease, you know you're kind of into it for the long haul and you're going to get side effects. So this is a case of Pemphigus. I'm just going to show you some pictures because I happen to have them and I think they're interesting. It's not a disease you're likely to encounter, although it does occur, obviously. What's interesting, you can see it looks like somebody just sort of dissolved the epithelium. See these shallow ulcers, as though the tissue just sort of disintegrated. Their palate. This guy had it all over. This was when he originally came in, and he was not very compliant with therapy, and he really tended to progress on him. He had a lot of other medical problems, and it was logistically, it was a difficult case. This was his tongue, ventral tongue was a mess. This was a case from a long time ago. You can see the ulcers in the back. Now she actually had enough scarring that she had difficulty opening her mouth. Same patient on the other side. This was another little small ulcer in a case of Pemphigus. So very nonspecific looking. That one is pretty characteristic though. That one is pretty typical of Pemphigus. Although unless you've seen a lot of Pemphigus, it's hard to look at something and say, ooh, that looks like Pemphigus. So this is what they say when they do direct immunofluorescence. The picture on the upper right represents Pemphigoid, and you see that line of that bright line there, which represents the basement membrane epithelial junction. That's where the antibodies bind, and the direct immunofluorescence has a stain in it which binds those antibodies and then fluoresces. And on the lower left, you have Pemphigus, which has that sort of fishnet pattern. What you're looking at is you're looking at all the outlines of the epithelial cells. So that gives you also a sense of what the histopathology of the disease actually is. So in general, with inflammatory diseases, we try to manage them whenever we can with topicals. So if we get, a lot of times we get very adequate management with minimal side effects or problems with systemic complications. But occasionally we have to use systemic steroids. And then there's another, when I say plus or minus steroid sparing medications, part of management of these in long-term cases to keep the steroid dose down as much as possible and to minimize the effects of long-term steroid use. We'll oftentimes add a secondary drug to that regimen to augment the therapy of the steroid, but allow for a lower dose and less side effects. And that could be, a lot of it depends on what the preference is of the person prescribing it. I tend to lean towards azathioprine or mycophenolate. Some people use a lot of methotrexate. Anytime we have these people treated with immune modulators, we have to watch for candidiasis. And I'm going to show you a tray in a minute here for treating disease on the gums. So this was a case of Lichen planus, and you can see it's pretty involved and pretty extensive, big ulcers. He'd had this a long time and was pretty uncomfortable with it. And normally something that extensive I would have treated systemically to try to get it under control, but he did not. It was contraindicated to him because of medical issues. So we thought, okay, well, we'll just go for it with the topicals. And so we treated it very liberally with the topicals. And after about a month, he really had a huge improvement. So that I really learned from that the topicals really, really can be very effective, even in cases where you think that they're just not going to be enough. He was brought under really good control just with the topical medication. We never had to resort to steroids, to systemics. This was a different case. This guy had a lot of medical issues too, and he had this horrible lichen planus all over. He also had a lot of xerostomia. He too had contraindication to systemic steroids, and he came in with a long history of management, including by some very good oral medicine people whom I knew. And as I looked through all of his notes, I said, well, he has been treated with all of the same medications I would use, all of the same topical steroids and the same preparations, the same antifungals. And then I thought, the one thing that I thought, that I noticed in looking at it, that he had never had the steroid and the antifungal administered. He never had the topical steroid and the antifungal administered simultaneously. They were always going back and forth. So I thought, well, let's do it at the same time. So we did that. We did that on just topical steroids and maintenance antifungal. And that was the ticket for this guy. And that was to me, that was really the ultimate example of what the point that I was making about the relationship between lichen planus and candidiasis and how they really kind of do go together. In this particular case, the key to success was in managing both cases, or both components simultaneously. In retrospect, he might be a case that might have done well with hydroxychloroquine too. I didn't think of that at the time that I was taking care of him. And here's another case of Erythema multiforme. A sudden onset of this ulcer, this crusted ulcer on the lip, ulcers on the tongue, ulcer on under the tongue. A differential for this would be herpes. And then after a week of treatment. So this is the tray that I wanted to show you. I gotta hurry it up. This is the tray that I wanted to show you. This is just a vacuum form tray, and we can put clobetasol gel straight out of the tube in that on the tissue contact side, and they can wear that for half an hour, once a day, twice a day, however long it takes, depending on the severity of the disease. And that can be a really excellent way to treat disease that's on the gums. I think I'm going to skip over these a little bit because we're kind of getting late, and I want to leave question for time, and I do want to talk about cancer a little bit. This was, we have a treatment for black hairy tongue. Scrub some of this on it, podophyllin. Okay, I do want to get into this. So, neoplastic disease, we have solar cheilitis. Everybody knows about that. There's sun damage to the lip that can result in dysplasias on the lip. These, although they tend not to be dangerous from a metastatic point of view, they can be really disfiguring if they get to be too big. So I really try to counsel people to use sunblock and to get over to a dermatologist to have these looked at when they, if they crop up. Carcinomas. We all look for carcinomas in the mouth. They can take a variety of presentations. This one on the palate, it's what you see, that abnormal vascular kind of puffy area, is carcinoma. This turned out to be a mucoepidermoid carcinoma that was below the surface. She had been sent to me for a different complaint, and I just happened to notice this on an exam. What was unusual was it did not involve the surface itself. It was just beneath. I felt this hard ball below the surface, and I biopsied it, and it was mucoepidermoid. One cancer that I found was, this lady asked for a denture adjustment, and by the time we got it to where it fit, I realized I was carving around a mass. And that turned out to be a hair follicle cancer. So things to be alert for in the mouth: anything which is persistent, it doesn't heal, it gets worse, it gets bigger, expands or spreads over time, should alert you to a possible tumor. Red, white, and mixed lesions, especially if it's on one of the cancer-prone surfaces of the lateral ventral tongue, floor of the mouth, or the soft palate, consider a possibility of a tumor. Neurological symptoms: pain, numbness, or motor deficits, a tongue that is swinging one way or the other. Palatal swellings are often salivary gland tumors. Risk factors of tobacco, alcohol, immune suppression, prior cancer. And then another one that I've seen this happen a number of times. I've seen several cancers present as isolated periodontal defects, refractory lesions not responding to treatment, and oftentimes, or usually, it's in an otherwise periodontally healthy person. So that shouldn't be the first thing you think about, but I have seen it several times. Don't be assured by somebody told you they had a biopsy and it was negative. It's never negative. It always says something, and you need to know what it says. I've had people give me biopsies that say severe dysplasia, and the patient says, well, it was negative. Well, it was for cancer, but that was then. Absence of known risk factors means nothing. The fact that they have something else, Lichen planus, can be a red herring. So don't let that reassure you. The fact that it's not where you expect to find it means nothing. And then sometimes they'll say, well, my doctor saw it and said it was nothing. Don't take anybody else's word for it. Satisfy yourself. This is a good example of that. This was biopsied approximately a year earlier, and it came back as a nonspecific ulcer, and that was it. There was no follow-up for it. Eventually, it wasn't responding to the topical steroid, and eventually developed into this. And by that time, it's obviously a cancer. Toluidine blue is a stain that we can put on that is picked up by rapidly dividing cells, so it can be really helpful in identifying good spots to biopsy, and also developing a sense of suspicion as to whether it might be dysplasia or not, or a cancer. This was being followed by a medical group in the East Bay as pharyngitis. Why they followed it as pharyngitis, I don't know, because they had a biopsy that said it was severe dysplasia, and by this time it was cancer. Here's another one. This guy said, well, I showed my doctor, he said it was nothing. So that doesn't look like nothing to me. This was talk about unusual spots. There's only a handful of cases of carcinoma on the dorsal tongue, and this one added to that. Notice also that the toluidine blue did not pick up on this one. So the toluidine blue is not infallible, and there's some places where it just isn't that helpful. Denture stomatitis, but it was kind of atypical denture stomatitis. It didn't really resolve after the antifungal treatment and leaving the denture out, so we biopsied it, and they laughed at me when I did it, but it turned out to be cancer. This was one that was sent to us. They had lost a tooth, couldn't control the periodontal disease, lost the tooth, built a bridge. Now the periodontal disease was developing around the other teeth, and it was sent over to us to rule out the galvanic problem. Well, this was a tumor. Another This was a recurrent nasopharyngeal carcinoma that the ENTs thought was a periodontal infection, but it was recurrence of a tumor. There you can kind of see it on number 15 up there on the left. Otherwise periodontally healthy. No reason to have a perio problem there. Another non-specific ulcer that was sent in by an ENT, his biopsy came back inflammation, and he wasn't buying that, so he sent her over, and we rebiopsied it, and this turned out to be a carcinoma. Similar situation, this was biopsied, came back as inflammatory, and this turned out to be, it was sent to our clinic, and this turned out to be a T-cell lymphoma, and kudos to the oral pathologist who picked this up, because that was really a heads-up diagnosis. So I want to say just a little bit about dysplasias. One of the big challenges that we have in oral medicine right now is what to do with these things that could become cancer but aren't cancer, or at least not yet. What can we do besides get rid of risk factors? We have this disorder called proliferative verrucous leukoplakia, which is leukoplakia that tends to spread. It has kind of a roughened surface. It can kind of work its way down into the periodontal apparatus, in which time the teeth get loose and they respond to no periodontal therapy at all. I've gotten to the point now where if I see it get down into the tooth, I just extract that tooth to try to keep this up on top of the surface rather than to get down into the alveolus. Tooth was extracted, but little by little, it keeps marching along and the teeth come out. Little by little. It's not that impressive looking. Little bits of white here and there. And you kind of play whack-a-mole with it, either with a laser or with electrosurge, try to get rid of it and get normal tissue to grow in. And sometimes it does. Sometimes it buys you some time. Did that with this one. Got a little bit worse, a little bit, kind of better a little bit, but then not again. And then he comes in with a lump, and then he's got a cancer there. But because we'd been following it so closely, the surgery that they were able to do was really minimal, and he didn't have to have any radiation. So even though we weren't able to control this one completely, we were at least able to minimize the management. This was another case of one that I've been following for a better part of 20 years now of ongoing dysplasias that develop. A PVL, he's lost teeth kind of one at a time over the years. Got this abnormal gingiva collar there. We electrosurge it off. It's better, but then it starts to recur. Finally, I biopsied it and it got some cancer, so I sent it down to UCSF, but when the specimen that they got out, they didn't get any cancer in it. So it may have been that the cancer receded somewhat after the biopsy. Who knows? So what to do? This is another ongoing thing that we have, how to deal with these pre-malignant or potentially malignant lesions. This was one. It had this dysplasia on the palate. This one we had some success with. It extended over onto the buccal also. Electrosurged it and got some response, did some more, got some better response, and eventually got it to clear up. Although it did come back a little bit here and there, we were able just to kind of keep at it. I eventually lost her to follow-up. So our options for treating dysplasia in this type of, I mean, in theory at least, they could have aggressive surgery, treat it like cancer, but the deformities that you can get from those types of cancer really make that a poor option, a lot of us think. You can do conservative removal, like with the CO2 laser or this electrosurgery, which is what we've been doing, and that, I think, tends to buy some time, but you really have to follow it closely. Or you can just do observation alone, and a lot of people do that. But in any case, frequent observation is essential. I tend to follow these people on at least a 3-month recall to keep an eye on it so I can be right on top of it. Then you see the people, you're trying to follow people up, and they have all of this abnormal mucosa, and you try to look at this and say, well, gosh sakes, what should I be suspicious of here? Where should I do the biopsy? So it gets to be a real challenge. And then a patient like this, You say, what is that lump over there? Well, this is actually normal tissue. This is what's left over after a partial glossectomy. So you lose a lot of your landmarks, you lose a lot of the normal tissue, and you have to try to follow these and say, well, gosh, what's suspicious? And it takes some, you have to follow them so you can see the changes. There's another one. This lady had radiation back in the early 2000s when they did the scorched earth radiation technique. And so she has a lot of, she had a lot of surgical deformities from her tongue cancer, a lot of radiation problems, and then she has this recurrence on her cancer. But it's hard to know what's normal unless you're following them all the time and can appreciate things when they change. So the role, our role in cancer, of course, is detection and diagnosis. And then dental preparation for treatment. We try to manage the risk, encourage them not to smoke. The dysplasia management that I've just discussed. And then we have ongoing follow-up and dental care in people who've had some of these problems. Try to watch for recurrences, manage their dental problems, be alert for things like osteoradial and medication-related jaw necrosis, and increased dental disease, and but that's kind of the subject of another talk. Anyway, thank you very much for your attention, and I think we have some questions. I can stay as long as we need to stay for questions, Martin.